So I'm going to cover hypertension and cardiovascular risks. But before I go, I was told we have to declare a conflict of interest. I have not received money from anywhere, but all I've done is I've represented the university at various national levels in NICE, developing cardiovascular risk prevention models for the country. And also, I'm a member of the Intercollegiate Stroke Working Party. So we develop guidelines for managing stroke, and then I'm also being a fellow of the British and Irish Hypertension Society in 2014. Before that, for many, many years, I've been a member. So the background I'll cover quickly, then I'll go into the pathogenesis of hypertension, why we get high blood pressure, what are the arterial changes which occur with aging, and how it'll affect the heart and the brain. So we call it target organ damage when we talk about it. And hypertension then has an effect on cognition, and so we'll cover that. And in between, when we're trying cognition, I'll also try. There have been lots of trials where they've tried to see how the hypertension and cognition are interconnected, and I'll go into that as well. So why are the arteries so important? Because they're the sort of connections between everything in the brain, heart, and everywhere else in the body. And the man is as old as his arteries. So the older you get, the arteries get stiffened. And one parameter, which very closely relates to the aging process, is your artery. If your arteries are so old, then you know exactly how old you are. And this was described, hundreds of years ago by Thomas Sydenham, and there's lots and lots of studies to show that this is the case. So what do the arteries actually do? So basically, in systole, when the left ventricle pumps, the aortic valve opens and pushes the blood into the aorta, which is one of the largest arteries in our body, and then it closes in diastole. And when it closes, this blood is pushed forward by the aorta. And it's also very important, this moment is when the heart actually rests and when it gets blood supply through the coronary arteries, which sort of come from this point uh, and to the right and left coronary, the two big arteries which come out. And so that is a very, very important step in, and this happens every second if your heart rate is 60, but if your heart rate is faster than 60, happens in less than a second. So when this waveform occurs and pushes the blood, the waveform then travels forward, and it goes on through the arterial system till it reaches a point of bifurcation. And in the human body, it's usually the first point is the aorta, and then you get a reflection, and the wave then gets reflected back. So this reflected wave then comes back, and if you got good arteries, it comes back and hits the heart in diastole. So that's good, because I told you that's when the coronaries are perfusing, that's when the heart is resting, gets more blood supply. Great. However, as we grow older and the arteries get stiffer, this wave reflection, which is measured as pulse wave velocity, comes back very fast and comes in systole. And that's what that is. It's coming in systole. And if it comes in systole, it's almost the time when the heart is actually pumping blood out into the aorta. So you're getting pressure from here, you're getting this reflected wave, which is also coming there, and the two meet there, which is not really good, because then the pressure starts to rise. So the pressure would have been like that, then it's going up like that, and before long it goes up and up and up and up. Okay, so that's why we get isolated systolic hypertension with aging. There are many other causes for developing high blood pressure, but the most common one is the arteries go, as you go older, the arteries get stiffer and we all get high blood pressure. And so I'm just going to put it all together. So we got three major components. We got the cardiac output, which will push the blood out. Then I told you about the vessels and the stiffness, which then pushes the blood up. And all of this will contribute. The main component in the middle of all of this is the aortic stiffness. This will then have an effect on the blood pressure. And three types of blood pressure are important for hitting the target organ. In this case, we're only concentrating on the brain. Okay, so it'll be the resting blood pressure, the average 24-hour, how it goes, and there are lots of things about that. And then at night when we sleep, the blood pressure should go down. It's called nocturnal dipping. And sometimes, for various reasons, that might not happen. And again, that's not good for the heart, the brain, and the heart, and everything else. So those are the three main components of blood pressure which will affect us. So in the brain, It'll be the cerebral blood flow, okay, the amount of blood flow which goes to the brain, which will be affected, and then you get cerebrovascular disease. It also has a role with amyloid deposition, amyloid presence, but that's not so much. It's mainly that upper part which is important. So vascular stiffness and cognition, what we know that stiff arteries, which causes high pulse wave velocity, is associated with a higher prevalence of brain lesions, lacuna infarcts, strokes, in other words, tiny strokes, uh, and a thing called white matter hyperintensities. Basically, WMH is when the vessels in the brain get smaller and stiffer, at the end of it, they die and they cause white matter. I'll show you what it looks like in a scan soon. Uh, it's also independently associated with memory. So this is based on population-based studies. And then there are areas of the brain, like the cortex, subcortex, it can vary with the microvascular system and relate to blood flow in the peripheries. So which areas involved may depend on how much, what is involved in the vascular structure. So this is what happens, and this is how clinically we sort of grade how bad it is. And this there's a different scoring system. One of the ones which commonly is called the Physica score, and basically they each of this white stuff here, see that all of those they're all white matter hypertension. So basically that bit of the brain is sort of getting affected, sclerosed, and the more of this is affected with memory problems. So that's called WMH. Um, so the interaction of these three things are very, very complex. So in this population-based study, in Iceland, they did this, where they look at the pulse wave velocity, which shows how stiff the arteries are. This shows the cerebrovascular resistance, how stiff the blood vessels are in the brain and the blood flow in that area. And obviously, we're talking about memory in this conference. And they have interactions, and they've got various mathematical formula they work out. That also is then related to the white matter hyperintensities and memory, and then they work out the complex interactions between them. We're not interested in all that. All we have to know is there's this complex interaction, which most of these people, I know that many of them, they're all engineers who work on vascular stiffness. So they use formulae to treat it like a machine and then work out how much it actually affects. What we need to know is the consequence of hypertension. So all of this, which I told you, this is one of the big cons. This is a postmortem specimen. Hypertension affects the heart big time. It increases the thickness of the heart, but that's not always good because it makes the free wall go really thick and the septum not so thick. This disproportionate thickening will result in heart attacks and other problems with heart failure, etc. So that is the heart. That I'm not going to talk anymore of the heart. In the brain, very common, and our previous speaker showed us a lot of slides based on epidemiology. This is what I see every week in a ward round. I'll see at least one or two uh, patients with intracerebral bleed, which will be this is a postmortem assessment. They're not dead when I see them, but it's associated with high mortality. But this is purely in the basal ganglia region, and hypertension is usually the cause for it. So and then this will then lead on to other problems. Uh, just a sec, I've got some other thing. I'll move this way. Okay, so evidence of blood pressure as a risk factor and what it does. I just showed you the end product. But elevated blood pressure is a risk factor for dementia and cognitive decline. There are lots of observational studies. But which blood pressure matters? The blood pressure in your midlife is more important than what happens in later life. And that disparity, it should be borne in mind. So it's we can't talk about treating blood pressure when you're old. Got to look at it midlife. If the pressure is a problem, got to get onto it. And actually, the association between late life hypertension is less consistent. It's the more midlife which reflects. And I think the previous speaker also showed some epidemiological data to confirm this. A midlife hypertension is the one which is going to reflect the long-term association. There's strong evidence that it's associated with vascular dysfunction, amyloid deposition, and pathological features of dementia. But these are all what we find in population-based studies. But when we go to the randomized controlled trials, so we like RCTs, right, where we give a treatment and don't give the treatment, and that's what hypertension specialists like. And in that things, there's not much evidence coming along. I'll show you, this is from a Cochrane review, but I'll also show you 2 or 3 sets of data where we've done this. And these things do not have a major effect in these trials. And most of it is because the hypertension trials don't go on for long years. They don't go on for years and years. It's 3 years, 4 years, 5 years. And I'll show you some data. And so that's not enough time to get the effect. So I'm going to change tack now. That's why I put this picture in between. So we're going to talk about the arterial stiffness and whether these trials and the medications have a role in prevention or improving cognition. And then can we change the vascular stiffness? That's a big $1 million question. I'll give a separate talk on that, not today. And then there's vascular stiffness and cognition. I've already told you there's a relationship there. The common question which people often wonder is Alzheimer's, because people like to see Alzheimer's, vascular dementia, although we all know there's a big overlap. So, but if you look at the pure Alzheimer's picture, all of these trials looked at that, then they did a meta-analysis, and if you're looking at that, it doesn't have an overall effect of treatment. Drug use will not, antihypertensive drug use, lowering the blood pressure will not affect Alzheimer's. And in fact, patients with Alzheimer's tend to have lower blood pressure. Okay, so that's not. So then we go on to the normal blood pressure lowering for prevention of cognitive impairment using the randomized control trials. And the 3 big trials, these were all done in the 90s and 2000s. There were trials which showed that you have to treat high blood pressure because you can reduce stroke by 36%. But that's very important. But on the other hand, the cognitive effect was small, partly because in all these trials, the endpoint can't be reached for cognition because it's so quick that they have to stop the trials because if you get an effect on stroke, you have to stop it. This one, although they had a long-term follow-up, MRC trials, a very famous trial, they use beta blockers. And beta blockers are the drugs which have least effect on the brain for cognition. And then this study had other problems called scope. We won't worry about it. Then there are 2 trials which showed some effect. And this is an ACE inhibitor trial where they used an ACE inhibitor called perindopril. That had quite a positive effect. But then when they sub-analyzed the group, it was only the people who didn't have recurrent strokes, because if you treat properly, your risk of strokes comes down. Then that the effect was not so positive. Cystio trial, I was involved with this, but the number of incident cases was so small, although there was a significant reduction in blood pressure. Significant reduction in dementia cases, incident dementia. The number was so small to make any sense of it. HIVAD trial, I was very closely involved with this. It's a huge multi-center trial with over 3,000 patients in 125 countries. This particular trial, we looked at dementia, incident dementia. And again, if you see that, the first year, second year, third year, the number of people having dementia is so small. That 200 is too late, okay, because we had to stop the trial here. And the reason we had to stop it is because the strokes are happening so frequently. It had to be done. And this is a placebo-controlled trial. The first time, and probably be the last time, where people can randomize patients over 80 years old into drugs versus no drugs. That's what we did, because there was no evidence. This was published in 2008. And you can see, as the incident dementia keeps going, the placebo guys seem to get more and more incident, whereas the ones who are on treatment are showing less and less. However, they didn't reach statistical significance either. And I'll show you. So if you can't reach statistical in 1 trial, 2 trials, do meta-analysis, the usual thing. So they did this first meta-analysis with 4 of the trials I talked about. It didn't favor treatment, okay? Then we added the HIVAD trial, and then we did another one. This is a paper in Lancet from our group. And again, it didn't reach statistical significance. Although you can see the graph is sort of tending to move, but it's not, okay? So the take-home message is this trial, which when I was doing my PhD, some of my friends gave me this slide. It was published then in the BMJ, so long time ago. And you can see here, this, and still, if you go to many of the hypertension conferences, this is a slide they'll use to tell you that even if your diastolic is 80, and if you can get it to say 85 or 84, that few millimeter reduction, you can see your relative risk of stroke goes from 0.5 to 1. So if you reduce that, you get a big reduction. Systolic, even bigger. So if you keep your blood pressure around 130, and then you have a blood pressure around 150, okay, that 20 millimeter change is enough to give you a zero point 0.5 relative risk reduction. So it is a big factor, and this is your take-home message. Uh, I, I think I'm going to end with just two or three anecdotes which will be interesting from real life. So this is coming back home to Queen Victoria, where she had vascular problems, and this, what I'm going to show you is from the notes which was reviewed, her physician's notes. Her physician was Sir James Reed, and his notes were reviewed by a group of specialists, and they published this. When they looked at his notes, they said the Queen had cognitive changes. They said that there was absent of any disease process, so they didn't have evidence, but they thought it was compelling but not confirmatory evidence, and the consultant didn't really examine her. Um, and his diary went like this: the Queen is rambling on. She's dysarthric. She can't talk. She cancelled appointments. The Queen says he looked into her eyes and he said this chronic hypertension changes were there, which is things we can all see. Then she became drowsy, confused, very confused. And then she had a facial droop, which suggests that she probably had a stroke. Then they said, she asked the physician, "Am I getting better?" But she said no. Uh, and she couldn't talk properly. And then he thought the Queen was going to that. Basically, he was going to die. And then he wrote, "Will be better," but unfortunately, she died. And so when they analyzed it, I just want you to just read this. In support of the view is a suggestion that intermittent cognitive impairment and the retinal findings and the late facial paralysis suggest small infarcts in the multicapsular area. And they would have then led to this likely scenario of the Queen having multiple infarcts, decreased perfusion, and then depression and death. Then we have these three people we all know who are Winston Churchill, Roosevelt, and Stalin. And all these people had thing in common. They all had systolic hypertension. They all were smokers. I think he didn't have a cigarette, but they have. And then they all had problems with cognition or not. We don't know. but what we know is that uh, Churchill, Roosevelt, they both died of intracerebral bleeds, and these were the people who then planned everything for us. So their cognition was, I hope, good, because that's the world we now live in. Okay, their planning post-war was crucial for our plans. I'm going to stop there. Thank you very much,